For those of you that don't know me, I'm the pharmacist here, one of 5 pharmacists. And if you do know me, my passion is supplements and vitamins. As a pharmacist, I don't typically like traditional medication unless it's absolutely necessary. So we're going to go through tonight, and hopefully I'm going to give you a perspective on bone health that you've never heard before. Probably half the material that I am presenting on tonight, I've never presented before. I just learned it myself probably 2-3 months ago in Chicago. So if you're thinking that I'm going to be talking about calcium tonight, you're absolutely wrong. I might spend 2 minutes talking about calcium. Or $100 a month on this particular box. Even though it is a great product, I'm not going to be spending information time on that as well. So hopefully what you're going to learn tonight is going to be something you've never heard before, which is, to me, is fascinating because I've known about bone health for 15 years, and I could say everything that I have in here, minus the calcium slide, I didn't learn in pharmacy school. So this is new stuff. So with that, we're going to go on an adventure, new perspective.
Did you go to traditional pharmacy school?
I did, yep. So I went to University of Madison, yep, did the traditional program, yeah. I'm going to kind of stand here so that the camera catches me and whatnot, but I'm not going to be moving around too much. This is always my medical disclaimer. If you've heard me speak here before, I'm not a doctor, so I can't stop your medication. I can't put you on new medication. I can only make recommendations and so forth. Some of my slides will get into that. All right, so that's that. So risk. So we probably know all this already. There is a huge risk for osteoporosis in our country, and there's multiple reasons for that. It just says here 10 million Americans with osteoporosis. Unfortunately, women, 80% of that number is you guys. For the 2 guys here, you know, you don't have to worry too much about it, but we should still be concerned. Again, 1 in 2 women over the age of 50 will break a bone because of osteoporosis. That's a huge number. That's scary. And I can't remember where I got this statistic from, but about 1/3 of those patients, you're going to have a re-break. 1/3 of those are never even going to recover from that first break, so that's a pretty scary number. The other 1/3 will repair just fine. A woman's risk of breaking a hip is equal to her combined risk of breast, uterine, and ovarian cancer. So that is just a huge number too in my book. I don't think we spend enough time talking about bone function and structure when you put it in that perspective. So there's a huge need to be cognizant of our bone health for a couple of different reasons too. I'll get into that. All right, so incidence and burden. There's just some more numbers here, but worldwide osteoporosis causes more than, I'll just round it up to 9 million fractures annually, resulting in a fracture every 3 seconds in the world. So that to me is, again, a scary number. Osteoporosis is estimated to affect more than 200 million women worldwide. 1/10 of women age 60, 1/5 70, 2/5 over 80, and 2/3 over 90. So you can see the progression there. The older we get, the higher our risk. Osteoporosis affects an estimated 75 million people in Europe, US, and Japan. So the big question then is, how do we fix this? Where do we go from here? This is a huge issue. Okay. So, like I said, what is bone tissue? When I typically learned about osteoporosis and bone health in pharmacy school, it was calcium and a little bit of vitamin D. And then, you know, the rest of the talk was spent on all of the bisphosphonates that are there, all the medications, and all the side effects. We'll talk about that in a little bit too. But again, there's a lot more to calcium than bones. So what are those? Actually, bone is made up of 25% water, so make sure you're well hydrated. That's rule number 1. Make sure you're getting water. Don't be dehydrated. Protein. We could spend all night talking about protein. Not just eating enough protein, but also assimilating that into our tissue. So I don't want you on an antacid or a PPI. We'll talk about that too in a few minutes. But if you're eating protein, just because you're eating it and it's on your plate doesn't mean it's getting into your tissue. So if you're on an antacid, Nexium, Prilosec, ranitidine, Zantac, Tums, then you're probably not absorbing and assimilating the protein the way that you should be. So we got to make sure we address that. These are just some different protein, little buckets, if you will, of different proteins under that heading. So osteocalcin, glycoproteins, amino acids, proline, hydroxyproline. That's not terribly important to remember, but protein in general, we've got to be getting that in our food. Crystallized mineral salts, that is important. That makes up 50% of bone tissue. That does contain type 1 collagen fibers. We'll talk about that towards the end of the material, what that means. Here's where the calcium and phosphate comes in. We do need to get calcium and phosphate, or phosphate in our diet. Generally speaking, in Wisconsin, calcium's not an issue. Who here eats cheese? Who here goes to Sendik's 3 days a week and gets a bag of fresh cheese curds for lunch? Still got my hand up. So calcium in general is just not an issue. We can assess it, and if it is, then we'll address it. But it's typically not an issue. So here's calcium again. Which type of calcium should you avoid? Does anyone know the answer to that? The calcium carbonate. So when I was in pharmacy school, in general, the recommendation is, well, just give your patient 1,000 to 1,500 milligrams of calcium in the form of calcium carbonate, which is Tums, which is sidewalk chalk, which is, well, there's a garage underneath where I'm standing, but typically if I were to walk outside 4 feet below where I'm standing, there's a huge bed of limestone across Wisconsin. That's calcium carbonate. In my opinion, calcium carbonate is garbage for a couple of different reasons. One is it has a lot of side effects, so it causes constipation. The other thing about calcium carbonate is it then, as in Tums, it reduces stomach acid, which then leads you into other issues besides constipation, because if you are taking something that's neutralizing your stomach acid, now you're putting yourself up, setting yourself up for failure for absorbing iron properly, because you need the acidity that you just neutralize with your Tums to get your iron in your body and your B12. And now you just reduce the acidity in your stomach, so now you're at higher risk for pneumonia and infection. So calcium carbonate, if you have Tums at home, unless you have heartburn and take it occasionally, I'd recommend you honestly just throw it out. Put it back in the soil. That's where it came from. Vitamin D3, we'll talk a lot about that tonight. Does anyone know the optimal level for D3? 50 to 70? Yep, that's a good answer. Did somebody else had a hand up?
I was going to say 10,000, so.
Well, dosing wise, yeah, 5 to 10,000 a day. So maybe that's my next, well, that's a different bullet point, but I usually go from anywhere about 50 to 90 is my range, so 50 to 70. When you look at typical lab values in, I'll just say the greater Milwaukee area, what I see from patients bringing in their labs to me, the reference range on those labs is 30 to 100. 90, 100, whatever the top range is, we can debate that. I think there's a much more stronger evidence to suggest that that bottom number should not be 30, should not be 40, it should be 50 or higher. So if you get a lab value back and your doctor says your vitamin D level is normal and you're at 35, I respectfully disagree. So look at that vitamin D level. Vitamin K, we'll spend some time on that tonight too. So there's a lot of misinformation on vitamin K that's out there. Vitamin K1, vitamin K2, MK4 versus MK7. There's a lot of acronyms thrown around there. We're going to talk about vitamin K2 tonight. Vitamin K2 is what is going to drive calcium to your bone tissue and not into your blood vessels. Vitamin K2 is just as important for cardiovascular health as it is for bone health. So you're going to fix your bones tonight when you leave, and you're also going to help your cardiovascular system. You're going to reduce your risk of cardiovascular disease at the same time. 2 for 1, which I always love doing. One thing that I just learned about in Chicago 2 months ago was magnesium. Magnesium, in my opinion now, is actually more important than calcium, given the fact that you have a normal calcium dietary intake, which again, in Wisconsin, we mostly do. So it really boils down to magnesium deficiency, leading to poor bone structure. And I'll hopefully prove that tonight. There's a lot of numbers out there. On average, 60% of the population is considered magnesium deficient. There's a lot of reasons for that. In general, we're just not getting enough magnesium from our diet, just because the soil is so depleted of magnesium in the first place. So even if you're eating organic vegetables and so forth, you think your diet is good, you still may not be getting enough magnesium. I personally take a lot of magnesium every day. I don't even count it anymore, but it's probably north of 600 milligrams a day.
What is your suggested
Suggest
dosage for that?
dosage amount. I would start at 200 milligrams a day for magnesium, and then I would just titrate each patient up to effect. And obviously that's subjective, but I'll base that on patient symptoms. And then we can really get into testing their magnesium level and their tissue level. I'm not going to get too much into that tonight, but yeah, you can. You want to start out with, if you want to put in, write a number down, 200 minimum for magnesium.
And you will talk about what kind, because there is many kinds.
Yes, for sure. Yep, we're going to spend some time on what type, just like calcium, we're going to, what type of calcium is important. It even goes even further with magnesium. The type of magnesium, the salt form, is critically important. And then bone meal. And basically, there's something called hydroxyapatite or MCHC. Another product we're going to talk about tonight is called Ostrophin PMG. This is my favorite. This is basically, to put it plainly, ground up bone tissue, to be honest with you. So if you're a vegetarian, vegan, and you don't like this idea, that's fine. We don't have to go there. There's other ways we can build bone. But again, to stack the cards in your favor, if you really need to just jump on board and get your bone tissue up as quick as you can, it's a great way to just add bone meal, add bone tissue right to your diet. So that's it in a nutshell. So if you fall asleep now, you've got the roadmap right here. But I'm going to go into I'm going to entertain you a little bit, not just have you read this slide.
Are we getting a printout, or do we have to go back to your YouTube video?
I think Kelly has everyone's email address, so I can email all the slides out, and then you have all this printed. Would that be good? Okay. Yep. Yep. So then you have to frivolously, write all this down for sure.
Okay, great.
Yep. Just sit back and enjoy. We could spend all night talking about different issues that revolve around destruction of bone. Obviously, for our pharmacy here, we deal a lot with menopausal women. So when the estrogen level drops at that magical age, whatever that is, typically between 48, 52, estrogen starts to plummet, and guess goes with it is our bone mineral density starts to drop. And for men, it's the testosterone. Our testosterone starts to drop, and our bone mineral density can drop. So we have to assess that as well too. We don't want to leave that out. Poor diet. We could spend all night talking about this. Long story short, eat an alkaline diet. Get rid of the wheat and the carbs and the excess sugars in your diet. So I mean poor diet, I mean eating an acidic diet. Eating a diet high in carbs and refined sugars. I can go on that. So acidic diet will almost always lead to bone fragility. So even if you are taking the calcium and the vitamin D and all these supplements, and you're spending all this money and time on repairing your bones, and your diet is junk, it's like on one end you're trying to build up your bone tissue, and then you go and eat your breakfast, lunch, or dinner, and you're tearing it apart. So we got to make sure we're eating a clean, healthy diet that's, and again, I don't want to spend too much time on this, but the big there's a book called Wheat Belly by Dr. Bill Davis. He's a cardiologist here, or was, in Milwaukee. He goes through a lot more in detail about eating wheat and grains and how that leads to acidity in our body. And then that, in turn, when we have an acidic circulatory system, when our blood is acidic, our body uses our bone tissue to neutralize that acidity. So it's pulling calcium and minerals from our bones, from our reservoir, from our metabolic reserve, and trying to neutralize the acidity of our blood, because our body doesn't like acidic blood, so it's going to try to neutralize it and keep it more pH balanced, and it's going to do that by pulling minerals from the bone to neutralize the acidity of the blood. So if you don't have acidic blood, then you keep your calcium where it belongs, so then you don't even need to take a calcium supplement. So and you don't have to leave here with a shopping cart full of vitamins tonight. Just change your diet. Medication depleters, this is a big one for me that drives me crazy. So PPIs are proton pump inhibitors. So I already mentioned this 5 minutes ago, but anyone that's on an antacid, talk to me, seek me out either tonight, tomorrow, all next week. I will be here and we can work on getting you off of an antacid. Because if you're on an antacid, you're stopping your stomach from absorbing calcium and minerals and iron and B12 and protein, and you're just setting yourself up for failure. So it's going to be a constant uphill battle. If you're trying to build bone and you're on a PPI, it's just going to be very, very difficult for you. Corticosteroids, like if you're on long-term prednisone or even topical steroids. I used to dispense in traditional pharmacy tubes and tubes of betamethasone, hydrocortisone, dexamethasone, you know, all the azones that were out there for topical creams. You know, you use those long-term, day after day. Those are getting into your bloodstream, and those are going to be pulling bone, basically mineralization out of your bones, and that is not a good thing. And then lack of resistant exercise. So you can walk around this building or your block at home 5 miles a day, 10 miles a day, and you're not going to build bone tissue. So I need you to do resistant exercise. I'm not an exercise expert by any means. Go seek out someone at a reputable gym. Tell them you need resistance exercise and you need to build bone tissue, and he or she will obviously help you with that. But if you don't do, you know, the yoga or Pilates or lifting weights or the stretching bands, whatever it is, water aerobics, something that pushes on that bone tissue, if you don't do that, again, you're not going to build bone tissue. You can take all the vitamin D and the calcium, and it'll help, but again, I want to stack all the cards in your favor, and I want to drive all those nutrients that you're going to spend all your hard-earned dollars on and get it into your bone tissue. So you've got to push on your bones so that they're stimulated to suck up the nutrients that you're going to be feeding it every day. My best example of that is I had a patient probably 2 years ago now, and I put her on a protocol, which I'll mention at the end. I won't share it quite yet, but she did resistance exercise training 3 days a week at Westwood Health Club. She found a trainer. They set up a plan for her, and then she went and did it by herself for a year. She did 2 supplements here that she got, and she grew 1 inch in her spine at age 65 and went from osteoporosis to osteopenia in 1 year. That's awesome. You can't find that with medication out there.
Then it's possible reverse.
What's that?
Osteoporosis, reverse.
Well, I can't use the word reverse because the FDA doesn't like me to use that, but
Okay.
yeah. She went from osteoporosis to osteopenia. So, yeah. Yep. At age of 65. And that's all she did. Yeah. I was pretty proud of that one. Again, I just said this already, but you can walk 10 miles per day and still not build the healthy bone that you need. So you'll build some. You'll build a little. I mean, don't stop walking. But my point is, you got to do resistant training, some type of resistance. You don't have to go and lift free weights, but we got to do something more than just aerobic exercise. All right, so we're gonna delve a little deeper here on these things here. So if you're going to take a calcium, if you need calcium, which is probably in this product here, this is the Cadillac of bone health, but we have a lot more cost-effective ways to do this now. Let's just look at the calcium in here. I can't even find the calcium in here. Where'd it go? It's in here as dicalcium malate or hydroxyapatite. It's basically a chelated type of calcium. The other calcium that I grabbed here, same thing, dicalcium malate, calcium bisglycinate, and calcium citrate. This is a blend of different calciums. In general, minerals have a different rate of absorption in the small intestine, and so what they're doing is kind of maximizing getting this absorbed throughout your whole intestinal tract. So if you got more doors opened up with different salt forms, they're going to absorb at different areas of your GI tract. So a better, a blend of different salt forms of calcium is going to be a better product in general. So I like bisglycinate. It's a chelated amino acid. So what it means is that mineral is actually attached to a protein, or well, in this case, an amino acid. And the way I think of it is your body thinks of that calcium now more as food and brings it back into the bloodstream, and then eventually from the bloodstream to the bone tissue. Unlike the calcium carbonate Tums, that's chalk. It's literally just neutralizing the acidity in your stomach and not getting absorbed, or very poorly absorbed. Enhanced absorption, easy on the stomach, doesn't cause the constipation. I already mentioned this. You could tell I don't like Tums, right? Do not take calcium carbonate. All right. Vitamin D3. We could spend 2 hours talking about vitamin D3, but it's required for calcium absorption from the GI tract. So in order to get, yes, calcium can absorb through the GI tract with a small amount of vitamin D, but again, let's stack the cards in our favor. Vitamin D helps to shuttle more of that calcium into the bloodstream and out of the GI tract. Activation of vitamin D is needed by the liver and kidney. So in order for, we're taking D3 as a supplement, but your body, your liver has to metabolize it, and your kidneys have to metabolize D3 for it to be activated. So if we have, so let's just say, and that's why the dosing of patients becomes variant. I could have one patient that has a vitamin D level of 50, and they may need 50,000 units or 5,000 units every day to get there. I might have the patient next to them with the same blood level of 50, and they might need to take 10,000 units. Depends on their liver function, depends on their kidney function. A whole slew of other things we probably don't even know about, that what is it taking for that patient to get their vitamin D level at that appropriate spot. So dosing on vitamin D3 does get tricky. It requires bile from the liver to be absorbed itself, so that's important. Vitamin D is nice because it's a fat-soluble vitamin. So you can take a large whopping dose of vitamin D, 50,000 units, 100,000 units even, and you'll absorb that and it'll store into tissue. And when your body needs it and it sees all this calcium coming in or whatever else it might need, it'll pull from those stores and get into the bloodstream and do the action that it needs. So vitamin D is actually more of a hormone. It has different actions throughout the whole entire body. And it's signaling other metabolic processes to go on and take place. So if somebody comes in, they don't have a gallbladder, they're going to be a patient that needs probably more vitamin D to get absorbed because they don't have enough bile to get that vitamin D into our bloodstream. We'll spend more time on this in a minute, but vitamin D3 should always be taken with vitamin K2. Not at the same time. It's not like you have to swallow them at the same time, but throughout the day, throughout the week, throughout the month, you've got to be getting both of those in, I would say on a daily basis, based on kinetics. You should get your D and your K2 in every single day. I'll explain that in a minute too when we get to the K2 slides. So just keep that in mind. D3, you're going to take K2.
It is one that are together.
Together, yep.
Pill.
Yeah, like right now you can buy D3 and K2 in the same pill. You don't have to, but it's more cost effective that way typically. But yeah, otherwise you can take, you can take a separate D3 in the morning and take your K2 at night. Your body doesn't care. But yeah, as long as you're getting it in somehow. Yeah. Dosing again is based on blood level. So one of the biggest questions I get on vitamin D3 is how much should I take? And I go, enough to get up to 50. So not a very specific answer, but it's a real answer. Realistically, I think most patients are going to need about 5,000 units of D3. So if you have to write a number down for D3, I would do 5,000 a day. But that number might be more, it might be less. Let's keep that in mind. There are side effects to vitamin D3, so we've got to be careful about that. We can't just take a ton of this. Kidney stones. So if you're prone to kidney stones, you've had a kidney stone, you never want a kidney stone again. My wife had kidney stones last November. It's the worst thing ever. And I didn't even have them. Awful. I took her to the urgent care twice at 2 o'clock in the morning, whatever it was. So if you get too much vitamin D, here's some other symptoms: confusion, muscle weakness, bone pain, weight loss, poor appetite. extreme thirst, nausea, vomiting, constipation. So you got to be careful with vitamin D3. You just don't go haphazardly. Get it. You know, if you start 5,000 units a day, you've never been on vitamin D. Do yourself a favor. In 3 months from now, go get your vitamin D3 level tested by your doctor. Go get a blood test. You can go into any physician and get that done typically. And then test it again in 6 months for me. And let's see where you're at. It does take time for that vitamin D3 level to get up to that 50. And it's not a linear scale either. So like, let's say you go in, you know, you start a vitamin D3 regimen today, you start on 5,000, and you do that for the next 90 days, your level might go from, let's say, 20 to 40. And you think, okay, my vitamin D level doubled, so I'm at 40 now. Can I go to 10,000 units and get to 80? Not necessarily. You might go from 40 to 50. You know, so there's a variance there. We got to test the D3 level in your body.
You are close to 80. You want to start decreasing the amount?
Not necessarily. I mean, I would say that's a good range. If you get up past 90 to 100, then I'm going to start asking you to back down.
Okay, nice.
Or suggesting, yep. So that's D3. Magnesium. Magnesium is, I thought this number was 200 until I went to Chicago and went through the seminar, but there's over 600 now, I guess. They keep adding to the pile of enzymatic functions that are magnesium dependent. Supports protein, DNA, and RNA synthesis. That basically every metabolic function in our body requires vitamin D with that statement. Maintains normal nerve and muscle function. I could tell you when I take magnesium, my muscles relax. Magnesium is a natural calcium channel blocker. I'm going to digress a little bit here, but in the world of pharmacy, there's a whole set of blood pressure medications called calcium channel blockers. Diltiazem is a very common calcium channel blocker for blood pressure. But long story short, magnesium is a natural calcium channel blocker, which helps lower blood pressure, helps relax muscle tissue. So magnesium is just got a neat pharmacology to it, or I should say metabolic effect, I should say. Calcium, I just mentioned that, the calcium channel blocker. It stabilizes cell membranes, which is important for just cell integrity, is very important. Here's a new point that I learned. Necessary for activating stored vitamin D. So if we want to wake up those stores, let's just say we're going to take a huge bolus of vitamin D, 50,000 units. We need magnesium to wake up those stores of vitamin D in our body to activate it and have that do action. Salt form is critical for benefits. So I like magnesium chelate. I don't like magnesium carbonate. Sulfate, oxide, I'm not a fan of those. So let's talk more about that. So what salt form of magnesium is important? Oh, actually I got my slides mixed up. Let me see what I've got here. This just goes about magnesium. Factors contributing to magnesium deficiency, I mentioned that already. Typically it's just soil depletion, to put it plainly, but our diet's just full of foods that don't have magnesium in there to begin with. There are GI conditions too. Here's a big one for me, coffee. If you're a coffee drinker, you're going to need more magnesium. So that 200 milligrams I mentioned, you might need 300 or 400 milligrams. I don't even want to tell you how much coffee I drink in a day, so that's why I'm taking a lot more. Balancing out my coffee. If you're on diuretics, so if you're on a water pill, if your doctor has you on asthmatic medication, birth control, talked about PPIs already, but diuretics cause you to lose more magnesium through your urine. Asthmatic medications basically burn up more magnesium. Birth control burns up more magnesium stores, so you need to replace that metabolic store that you had. So that's the issue there. And then we talked about PPIs already. Just you can't.
Is it the tea there? The tea is because tea with caffeine? Or
The coffee.
and the tea? Is it
Oh, and the tea.
because there is no natural herbs?
It's just that when you consume like the alcohol, coffee, and tea, your body's ability to process that material consumes up magnesium. So if I'm doing something that's consuming more of it, I need to replace. I could just lower my coffee intake, but I don't want to do that. So I'm gonna play the game and up my magnesium.
More magnesium. Okay.
Yep.
Dan, is that true whether it's caffeinated or
It didn't say.
Okay.
I don't know. I don't know if it's the caffeine in the coffee, right, or if it's the coffee itself. Yeah.
So those of us who drink decaf aren't necessarily.
You may not. Yeah. Yeah. You may not be. Try it and let me know. Yeah. Yeah.
Okay.
Yeah. All right. So magnesium. Magnesium depleted soil. So this, all our crops that are grown in the soil typically in general is just doesn't have enough magnesium to draw it in. This is a depiction. This is a seminar that I went to actually in Pewaukee from Standard Process about a month ago. But on the left-hand side, it's hard to see, I know, but this is from, I think, a beet leaf or bean leaf. But the leaf, not as green as the adequate magnesium side. This is grown in, this bean plant was grown in magnesium depleted soil. So if you're looking for, just going to the grocery store, right, looking at product, you want to go for the darker green leafy vegetables. That is going to have more magnesium in that product. So there's a whole study done. Well, wherever it said it was done. Actually, this was done in China. So going back to how do I know if how much magnesium, that kind of thing. There's all kinds of signs and symptoms of magnesium deficiency: headaches, brain fog, muscle twitches, tightness. That was a big one for me. Muscle cramps. When I get Charlie horses or muscle cramps at 3 o'clock, 4 o'clock in the morning, I'm like, oh my gosh. I go downstairs and I take my magnesium powder and I throw that in with a teaspoon, or no, not even a teaspoon, half a teaspoon of sea salt, and I drink that. Oh, it takes it away right away. Poor glucose management. This is more of a very subtle thing, but if you're having poor glucose management, you get hypo or hyperglycemia. There could be a magnesium deficiency there. That would have to be teased out by a physician, but it's out there. Mood changes, fatigue. So a lot of, obviously there's a pretty vague symptoms here, but if you can, check off 3 or 4 of these on your own list, consider adding some more magnesium to your regimen. So again, I kind of digressed, away from bone health for a little while there, but and this slide does the same thing, but magnesium is critical for all types of different biochemical processes. This is magnesium is binding to ATP for energy. So ATP is the fuel that our body runs on. If we don't have enough magnesium, we don't have enough fuel. The slide before mentioned fatigue as one of the symptoms of low magnesium. This is why we're not getting enough ATP generated, just because of a magnesium deficiency. Who would have thought? Something that simple. Or down that same list here, estrogen metabolism. If you're, we see this all the time, or I see it all the time here at the pharmacy. A patient comes in, they get estrogen therapy. That's probably 60% of what I dispense every day out of this pharmacy. Patient comes back in a month, gets her refill. She feels great. I'm the best pharmacist ever in the world. She comes back 2 months later, and I'm the worst because her hot flashes are back. I'm like, oh crap. So then I go grab her a bottle of magnesium and some B complex, and then she can metabolize that estrogen because she just depleted her stores of magnesium between day 30 and 90. Now I put her on a couple of supplements to get that estrogen metabolized out, and now her hot flashes are gone again. Where you might think, oh, your hot flashes are back, I have to raise your estrogen dose, which happens all the time, and then the patient feels worse and worse and worse and worse, and you're like, oh crap. And it could be just as something as not enough magnesium in that patient's diet. So, neurotransmitters are on that same line. Dopamine, 5-HTP, which is like your serotonin, your norepinephrine, your adrenaline stuff. Somebody that's depressed, has low, has fatigue, could be as simple as a magnesium deficiency. Very, all things considered, this is very cost effective. It's something just so simple to try. It's probably, if I had to look at the numbers today, that's probably one of my one of my top 3, top 5 supplements that we sell here is magnesium. Everyone should go home with magnesium. It's not only for bone health, but it just helps with so many other things. 600 of them. I only went through a few of them though. One last thing that's mentioned here, magnesium is a cofactor for glutathione synthesis. Why is that important? Why am I mentioning that? Glutathione is the most potent antioxidant, is the way I describe it, in the body. That your liver makes glutathione, and it helps to recharge vitamin C and vitamin E in the body. So when you're looking at an antioxidant, take some magnesium to boost your own body's production of glutathione, which is then going to increase your body's own ability to have more powerful antioxidant activity.
Dan?
Yep.
Is magnesium like vitamin D in that there has to be enough bile in the intestine to absorb it?
Nope.
Okay.
Nope, not at all.
Thank you.
Yep. So which form is best? We just asked that a little while ago. So which salt form of magnesium do we want to take? Well, for heart health, it's taurine. For sleep anxiety, it's glycinate or bisglycinate, which is the one I sell on the shelf. For bone health, it's magnesium chelate or the reacted magnesium that we sell on the shelf. Or what you get to sample tonight is a whole, if you want to, there's a table set up to sample a whole food-based magnesium. And so why is that important? The seminar that I went to that was put on by Standard Process in Pewaukee, they just launched a new product which is a plant-based magnesium. So when we get into the science of magnesium, it's critical of what the salt form is because that depicts how well it gets absorbed. So similar with calcium, the salt form depicts how well it's absorbed. Same thing with magnesium. So what they did, this is just one study, I'll briefly describe it. They took mice and they fed them a magnesium depleted diet. And they got all these mice basically on the same baseline. And then they split up those mice and they gave them different types of magnesium. And then 15 days later, they looked at their magnesium level, but in their cerebral spinal fluid, which is important because it tells me a lot of different things. It tells me it got out of the GI tract, into the blood, and actually all the way into the tissue, into the brain, that kind of thing. So here was the placebo group, magnesium citrate, bisglycinate, threonate, and guess what happened here with the plant-based magnesium? It is much more, and this was clinically significant as well. So take-home message on this, if so the best two things I've got are the bisglycinate. I don't have threonate on my shelf, but I can order it. But bisglycinate is very well absorbed. And then, again, the plant-based magnesium. The only downside to the plant-based magnesium, in my opinion, is it's expensive. So cost-benefit ratio, for a month's supply, it's like north of $50. I think it's $58. So that to me that's a lot for one supplement. I can get the bisglycinate. I can get a month's supply for, I think, $25. So I would start with the bisglycinate. It depends on the patient, of course. If somebody is very osteoporotic, they got all types of other symptoms of magnesium deficiency, well, and money's not an issue to them, well, I'm going to give them the Cadillac of magnesium. I'm going to suggest they get the plant-based magnesium. The other drawback is it's only in a powder form, so it's not in a capsule form. It only comes in these little sachets, and you got to mix it up. So there's a little drawback there too. It's not as easily,
So if you mix it up like in a protein shake or something?
You could do that, yeah. It mixes pretty well. But yeah, you could mix it just with water, but I found I was chasing powder a lot.
Yeah.
So a smoothie would be a lot better. Yeah. Hopefully they'll, yeah.
Excuse me, I was always taking the reacted mag.
I'd keep doing that. I mean,
Would you say next time switch to one of these because you think these are superior?
no, the reacted mag, I would stick with the reacted mag.
Really?
Yeah, unless I would only switch to the plant-based magnesium if it was, again, if you didn't care about the price and you just wanted to, I would say if somebody's going to commit to the plant-based magnesium, you're going to want to do it for at least 6 months or a year, and do it. And then, for me, I'd want the proof myself. Like, I want to do a DEXA scan before I start this plant-based magnesium, and then do it, do it for a full 6 to 12 months before I repeat my bone density
What's the
scan.
other one you want? The bis?
Oh, bisglycinate. That is the same thing as the reacted magnesium.
Oh, it is the same
Yes.
thing.
Yep.
Okay.
Yep.
Okay.
Sorry about yeah.
So you do a scan, you mean a bone density?
Well, your doctor would.
Right.
Yeah. But yeah, I would suggest if you're going to spend the $60 a month just on a magnesium, I want proof for myself to do a scan before and after, baseline, and then 6 to 12 months out.
Can you go to the before slide because
Yep. Yeah, so basically, take home on this, yeah, the magnesium chelate is the same that I sell on the shelf called reacted magnesium. Yeah, I'm sorry, yeah.
if you want to have good bones and sleep, what you at the same time you have
You could actually, this is a little bit, this is well, this is not specific enough. You could actually take magnesium chelate for sleep and anxiety as well. Okay, yeah. Glycinate will work just fine. Glycinate is a little less expensive than chelate. Yeah.
Does it support both? Yeah.
It does, but this is better.
Okay, for bone.
Yeah. If I were just to go after bone
But that
benefit,
will help you for sleep.
that's right.
Okay.
Yep.
Which
Sorry.
one are you pointing at?
What's that?
Which one are you pointing at?
Oh, the chelate. If I was just going to build bone, I would take the mag chelate,
Which is the react?
which is the reacted.
Okay.
Yeah.
So can you get all three of them in one?
No. You can get the glycinate and the chelate in one, but Standard Process is the only company I know of that makes this plant-based one. Yep.
How young do you believe people should be on this?
How long?
How young?
How young?
Like, okay, say my son
Uh,
is 34. Do you believe a 34-year-old?
I wouldn't supplement unless I know there's an issue.
Yeah, so
Yeah.
more people like my age. Okay.
I wouldn't start, well, strictly for talking about a bone function,
Yeah.
I would, I'd be, checking at, let's just say age 40,
Yeah.
45,
Okay.
that kind of thing, and seeing if there's an issue. And then if there is, then I'd go after it.
Okay.
Yeah.
But in general, I think magnesium
In general, everyone should be on magnesium. Yeah. For reasons other than bone tissue. Yeah. Yep. I'm going to switch gears to, and I'm yammering a lot here, aren't I? I'm already at 45 minutes. K2 for calcium delivery. So why is this important? So K2 will take the calcium that the vitamin D pulled out of your GI tract, and it's going to hand deliver it to the bone tissue. That's the way I describe K2. K1 is different in that this helps. K1 is what helps with coagulation. That's how warfarin works. It actually interferes with K1. I'm going to skip that because I'm running over. So K2 as MK7 has a long half-life, supports bone and cardiovascular health. We're going to get to the next slide that delves more into that. Vitamin K2 as MK7 has been shown to inhibit circulatory calcification. What does that mean? So when you're taking in all this calcium and vitamin D and not K2, guess what's happening to all that calcium that you're taking in? Or even, let's just say, from your diet. Let's just say you grab a vitamin D3 off the shelf, a 5,000 unit, you start taking that, and that's all you do. Now the dietary calcium is going to be absorbed at a greater rate from your gut into your bloodstream. If you don't have K2 around, that calcium is going to end up, some of it's going to end up in your bone tissue, some of it's going to end up in your arteries, and that's not good.
Is that the same for dietary calcium?
Yes.
Okay.
Yep. So if you take calcium from a supplement or just whatever you're eating in your diet and you add vitamin D to your mix and you don't add K2, now you've just set yourself up for failure, essentially. I mean, there's pros and cons to it. You're going to help your bone tissue out, but then you're going to sacrifice your cardiovascular system in the process, which is not good. There's all kinds of clinical trials that have now substantiated this too. So I'm not going to read through all of this just for the interest of time, but there's study after study that shows not only does it improve bone structure via DEXA scan, but it actually reduces calcification of the arteries in our body, which is, we don't want calcium in our arteries. We want it in our bones, because if we put calcium in our arteries, they get hard and stiff, and then they're more likely to get clogged up, and then the blood pressure rises, and it's just never good. So there's that. I'm going to skip over this, but patients have brought up over the years of, well, doesn't your GI tract make, doesn't the bacteria in your GI tract make K2? And yes, it does, but in my opinion, it's not enough when you're going after building strong bones, your natural flora is not going to make enough extra K2 to drive all that added calcium now that we're driving into your bone tissue or into your blood, into your bones. So long story short, taking a probiotic to then up-regulate K2 production in your GI tract typically is not enough. And there's all kinds of reasons for that I'm not going to get into tonight. Important note, so there's a lot of different vitamin K2. So there's K1, blood thinning. K2 is for calcium delivery. In that small bucket of K2, there's something called MK4 and 7. The difference there is half-life, and basically at the end of the day, it's effectiveness for the patient. The K2 as this Q7 has a longer half-life, so it lasts longer in the body. It's doing more work, and it's driving, there's all kinds of studies with this too, but it's driving more calcium into the bone and away from the bloodstream, essentially, away from the cardiovascular system. The only product that I know of that sells the K2 in the MK7 as this Q7 Pro is Orthomolecular. And I believe there's 17 different studies that prove its effectiveness, not only in bone, but in cardiovascular health. I'm not going to get into all of that, but there was, reference to, there's a Calcified Tissue International Journal. There was one study that I looked at, it's relating K2 and arterial stiffness there's a word missing here, in kidney transplant recipients. But what they were looking at is the blood flow to the transplanted kidney. You want that to be very loose and malleable. And what was happening is that artery was calcifying and getting stiff, and then blood flows diminished to that transplanted kidney. You start giving them K2 in that form, and the calcification starts to dissipate, which is a beautiful thing.
So it's not too late for those of us who've been taking D3 without K7?
Yes, it's not too late. Yep, we're going to start pulling that calcium. If we were to do a calcium score of your arteries, right, it'd be elevated now. We're going to start pulling that out. We're going to start stripping that away and taking that calcium and pulling it out and then putting it back into your bone tissue where it should be.
Any side effects to
The K2?
K2?
Not that I know of, no. D3, which we talked about, but not the K2.
Okay.
Yeah. Well, I take it back. There's one exception to that. Maybe that's on my, if you're on, like a side effect would be if you're on a blood thinner. Because there is, so K1, like I talked, there is some cross reaction, I guess I'll say. K1 is typically for blood thinning, but there is patients that are on a warfarin or a blood thinner should consult their doctor before starting K2. So if you're not on a blood thinner, you don't need to worry about it.
That K2 that you, K4 suit?
Yep,
carry
that's
there?
that's this
That's that
Mino Q7. Yeah, if you're taking the K4s,
taking the K4.
then you're good. Check that box. Yep, you're good. All right, I'm switching gears again here, but keys to lowering risk. Remove any offending medication that you're on. Obviously, consult your physician. I want to get you off the PPI. That's my big thing. If you're on long-term steroids, we've got a doctor, you and doc sit down and come up with a plan of getting rid of the steroid. Assess hormone levels. If you don't know what your estrogen or testosterone level is, you need to know what that is. If it's low, we need to treat. Stop drinking alkaline water. Don't raise your hand, but who here drinks alkaline water? Alkaline water, yeah. What is alkaline water is like pH above 7, and they're claiming that this whole pH balance and reducing cancer risk by having an alkaline body and drinking alkaline water. You can have an alkaline body, but don't drink alkaline water. It's basically like drinking Tums, basically, in my opinion, to put it simply. So if you're drinking water that is basic, it is turning the acidity in your stomach to a basic environment, and then you stop absorbing your calcium and your magnesium and your iron and everything we just talked about. So you want an acidic stomach. That's the biggest challenge I have. Well, I shouldn't know. One of them.
Water alkaline? How do you know what?
You'd have to measure it. But there's actually like bottled water, and there's bottles that they sell now that you can like pour, like a Brita filter almost, that alkalizes the water and makes it above a pH of 7.
What if it's RO?
RO, you're typically fine.
Oh.
Yeah, unless you know you've got.
What about the person who have acid reflux?
That,
They are drinking that water because
we need to fix the acid reflux. We need to get him off of that alkaline water. Yeah.
How are we testing our water? With what?
You can do a pH strip.
pH tester?
Yep.
And
That's
wait, we want to drink.
You want it below 7. Well, whatever water you're drinking, you want it below 7. And it typically is, yeah. pH below 7. Stop taking, I think I've beat this horse to death here. Stop taking PPIs. Consult your physician first, obviously. You don't want to just stop a PPI. That'll be the worst. I personally have done that, and it's the worst thing ever. So don't do that.
Well, that's my question is, how do you do that?
Well, you'd have to set up an appointment with me, and it's a slow process. There's a whole series of doing that. Because if you're on a again, not that it's the end of the world, but you're stacking the cards against yourself. Yeah, yeah, yeah. But we gotta, yeah,
Chasing your tail.
yeah. We gotta. There's different ways around that. I got a whole protocol I've developed over the last 10 years that is great success. Not perfect success, but pretty darn good.
You think they go in?
Yeah, yep. We talked about this already. Start eating a non-acidic diet.
What's an example of non-acidic food?
The green leafy vegetables, non-grains, olives, olive oil.
Are you talking about
Paleo would be a good example. Yep, exactly. Unrefined foods, whole foods.
absolutely no grains?
Very little grains. Give me less than 50 grams a day of carbs from grains.
And how are you supposed to not keep losing weight?
Well,
I've been on keto,
yeah.
and I'm going to tell you.
Well, yeah. If we get into the weight loss, then yeah, you're gonna have to go more for sure. Yeah, yeah. I don't want to get into that tonight.
And I was under the impression you weren't supposed to eat a lot of meats.
Well, because meats. Well, you want to balance that with vegetables. More, vegetables. When you're going after meats, you're going. For me, it's more of healthy fat: the olives, the olive oil, the coconut oils, grass-fed butter to a small extent, and then veggies.
Which there's some conflict now about coconut oil.
Yeah, I respectfully disagree, but yeah,
Okay.
yeah. And then start exercising with resistance. We talked about that already too. So again, all this we could do. This is all non-supplement, non-pharmacological. This isn't cost.
About resistance, you're talking about actually stressing the muscles.
Yep, which is then putting pressure on the bones. Yep. Yeah, weightlifting, but like even those, to a point, but it's more.
Would depend on how hard you're cycling.
Well, yeah, the resistant bands, the yoga, the Pilates, the whatever your trainer. Again, I'm not the expert on that part of it, but like I said, you can't walk around the block enough times and build bone. Yeah. All right. I'm almost done here. Bone's dynamic. We got to keep that in mind too. It's not this skeleton. It's not like the 2x4s in our house. This stuff is growing. Bone marrow. Our bones, red blood cells come from there, from the marrow. So up to 4% of new bone is generated every year. So that's important to know. You can turn over bone tissue so much year after year after year. And I want to start putting in good nutrients into my bone, my new 4% every year. It doesn't seem like a big number, but multiply that by 10 years, that's 40%. If I can, I can really add some good bone density relatively quickly.
Is the converse true? You lose 4% if you don't do anything?
Not necessarily, no. No. But I would. This is to put this in context. This is a healthy individual. I'll put it that way. Yeah, and that's obviously subjective, but yeah. I recommend not preserving old bone. What I'm getting at with that statement there is bisphosphonates, which is the pharmaceutical class of drugs, otherwise known as Fosamax, Boniva. I don't know, you guys know it better than I do now because I haven't done that for 10 years, but all the Fosamaxes and Bonivas I dispensed over the years, it's like, I always use the analogy of it's like termites going through your house, and instead of replacing the studs in a new structure, they just shellacked it, sprayed sprayed polyurethane on it, and call it a day. Like, why is that good? Bad idea. Yeah. So, yeah, why stop osteoclasts from turning over old bone? You need this natural turnover progression. So there's two cells in the body. I'm oversimplifying this, but there's something called osteoclast and osteoblast, and I always mix them up because I think of osteoblast as blasting something apart, and that's not the case. It's the osteoclasts that are digging up and blasting out old bone, and it's the osteoblasts that are actually laying down new bone. You want to have a balance of those two cells working in unison with each other. You want to dig up the old bone that the termites kind of ate through, right? That has been demineralized for one reason or another. And you want osteoblasts coming in and laying down new bone and new matrix. I've way oversimplified that, but that's a scoop. So yeah, bisphosphonates. I'm kind of circling way back from one of my first slides, but Ostrophin PMG. So I told you the story about the patient that was 65 that grew an inch in her spine. It went from osteoporosis to osteopenia in 1 year. She took K-Force and this. She took 3 tablets of this a day. So she took, this is basically bone meal. Yep, and she took K-Force, and she went to Westwood Health Club and did weight-resistant exercise 3 days a week for 30 minutes. Yep.
And that would be really important. You take K, magnesium.
Yeah, she didn't even take magnesium. She just took Ostrophin and the K-Force and exercised.
And that was the only thing.
And that was the only thing. So if you want to call, K-Force is the K2 plus the D3.
You're calling it K-Force?
I call it K-Force. It's that, well, that's what the company calls it. I'm sorry. Sorry.
Dan, are there things in the Ostrophin PMG besides the calcium?
Well, it's literally, there's calcium. It's literally ground up bone tissue. So there's everything. It's the water, the protein, the collagen.
Where are they getting that stuff from?
Australian veal.
Horses or humans?
Veal or cows. So you got to be comfortable with that. Yeah.
So if I'm already getting my 1,000 to 1,200 of calcium from food,
Mm-hmm.
would taking the Ostrophin PMG kind of put me over that magic threshold of getting too much calcium?
No.
No.
Mm-mm. I would recommend you not take an added calcium supplement.
Right, and honestly, I stopped taking calcium supplements because of the study that I had read about in Gut magazine where it talked about the 2 to 4 times greater incidence of premalignant colon polyps with supplemental calcium.
Calcium, yeah.
So that pretty much scared me because I've had a premalignant polyp in the past and I prefer not to have it go the next step.
Yep.
So I frankly got off of that, and I've just been taking the magnesium D3
And
fish oil.
and yeah, we didn't even get into that, but D3 has been linked to reducing risk of colon cancer.
Yes, except that in that study, they found that the increase in the premalignant colon polyps was about 230% for just calcium supplementation. But if they looked at people who did calcium supplementation with D3, it went up to over 400% greater increase.
Which
So-
calcium was driving.
Which tells me that vitamin D is certainly absolutely driving that calcium, and it drives it right into the colon and
Yep.
makes a polyp.
Yep.
Is what it
Yep,
told me,
yep.
which is why I'm particularly interested in the K2.
But if we were to add, K2, now we've taken that calcium that was driven to the colon and put it into the bones and pull it out of my arteries, basically. Yeah.
I'm just,
Yeah.
I don't want to take any of the osteoporosis drugs, but I don't want to overdo
From what you've
the
just told me,
calcium
just
either.
do some K2. Yeah.
Okay, just do K2.
Yeah.
Okay.
And then reassess in a year. Let's
Okay.
see. Yep. I mean, this is a marathon, not a sprint. We all know that. I mean, it takes a
Yeah.
long time, right? So if you're going to commit to the Ostrophin PMG, like the patient story that I shared, I told her right up front, I said, if you're going to do this, don't waste your money for 1 or 2 or 3 months, commit to a year. And she did. And she was, I remember the day when she walked in here, like, why are you so happy? She grew an inch at 65, right?
Over the moon.
Who grows an inch in a year at 65, right? Yeah. Not that that's typical, right? I don't want to overpromise the world here, but
We're talking the Meno Q7, K2, and there's a lot of,
yeah. There's a lot of K2 out there.
K2 that says it's something 7 on the internet.
Yeah, there's MK4 and MK7.
Right,
And-
MK7,
and-
so what's the difference between MK7 on the
Eh,
internet and
yeah,
this
the-
orthomolecular?
It goes back to the actual structure of it. There's, not to get into too much of the biochemistry, but there's something called cis and trans, the way that the molecule is set up. And the pro has, and I can't remember exactly, I believe it's all trans, which has, again, more clinical effectiveness and a longer half-life in the body. And that,
Even if it says it's MK7 on the internet,
it's not, unless it's that brand name Meno Q7. Don't get me wrong, that's still great to take MK7, but again, if I were to really go after this, I'd rather have you take the Meno Q7 because I have more studies to prove that it's more clinically effective. Yep. So I'm not saying not saying it's wrong. Yep.
What is the compound for the Ostrophin? What is that?
What is the compound? Ostrophin? It's just a fancy name, but it's just another name for bone meal. It's ground up bones, to put it plainly. It's more than that, but it's, in essence, that's what it is. Yeah. So so again, going back to that patient example, she didn't start taking calcium, she didn't start taking magnesium or anything else. So if a patient comes in and their diet's good, their calcium's good, their magnesium, they're either taking that or they've done an assessment and they're getting all those nutrients from their diet, great. That's where a patient would just come in and get Ostrophin PMG, some K-Force, and go to the gym. That simple. Yep. Or it could be, right? Yep. Dosing, I just mentioned this, but it's either she took 1-3 times a day. You could even go up to 2-3 times a day. You do want to split it up, though. Don't swallow all 3 at once. You're going to have only so many transport systems across your GI tract to get that stuff in. So I want to just trickle it throughout the day.
Wait, what are we taking multiple times a day?
The Ostrophin, the bone meal.
Oh, the bone meal.
Yeah.
Okay.
Yeah, take it. Yeah. I think I'm going to skip through all my collagen slides. But this is a whole nother talk I have on my YouTube channel already. I added this at the last minute, but not that this is a be-all, end-all. I mean, collagen is important for the matrix of bone tissue. So if somebody is just, their T-score is, off the charts in a bad way, we might even consider wanting to put collagen on board, help with the bone matrix, help with their ligaments, tendons, and all of that.
It tastes disgusting.
Yeah, it does. I put my collagen in a smoothie, which helps. So that's that. I think a lot of these are talking about collagen now. I'm going to skip over these. Collagen matrix is critical for bone structure. You're going to get some collagen in that Ostrophin PMG. Not as much, but you'll get some. Collagen helps to slow down bone breakage. I got a lot in here, didn't I? Same thing going back to with vitamin D and kidney stones. Collagen has that same precaution. If you're prone to kidney stones, had a history, don't go and grab the collagen on the shelf without consulting the doctor.
Can I hop in with a different question?
Sure.
Are the videos on your site different than the YouTube videos?
No, they're the same.
Okay.
There's actually more. We stopped adding our seminars on our web page for different reasons, so there's more of them on our YouTube channel.
Okay.
Yeah.
How do you find your YouTube channel?
YouTube channel. So just obviously go to YouTube and then just type in search MD Custom RX. Yeah, in the first one it'll pop up with our logo. Yep. Yep. Oh my God, I'll skip through that. All right, quick recap. I think this is my last slide. You're going to assess calcium. However, your focus is going to really be on magnesium. Magnesium activates vitamin D, plus a million other things. Helps to balance out that acidity too in our body. Start taking vitamin D. Always take K2. We now learned with vitamin D3. Vitamin D is going to pull the calcium in from the GI tract into our bloodstream. That's what the D3 is doing. Now that we got all this added calcium in our bloodstream, K2 is going to hand deliver it to the bone tissue. And not only that, but K2 is going to pull the calcium that we inadvertently deposited in our blood vessels and put that back into the bone. Remove your bone destruction. So if it's a hormone imbalance, stress, poor diet, medications, we got to be aware of that.
Recommending the spit test for the hormones?
Say that again?
Do you recommend the saliva test for the hormones?
Not necessarily. I mean, that's what we prefer here, but it's not critical. You could do a blood test too. Yep. Either way is fine, especially for the initial assessment. Yep. Exercise is a must. I mentioned that already, 3 times per week or more if you can, and it's got to be resistant. And I think that is it. I went a little bit over than I thought, but questions?
Question.
Yep.
My magnesium